Hey again, Bob from Rosk. We're going to do a quick review on vasodilators. So this review will include nitroglycerin, nitroprusside, nicardipine, and clevidipine. As the name implies, these medications dilate the vessels of the body and result in a reduction of blood pressure, and we typically use these agents in critical care for cardiac processes and also hypertensive emergency or urgency. So why the heck are we talking about this class of medication during a shock lecture? Well, sometimes in shock states, cardiogenic shock specifically, we might use these medications to decrease SVR, promote forward flow, and to reduce the cardiac stroke work. When using these medications for cardiogenic shock, our treatment decisions need to be guided by advanced hemodynamics. I'll also add a cautionary tale or statement that these powerful dilating medications shouldn't be used in severe aortic stenotic patients that are in shock. Dialing out these critical aortic stenotic patients is a good way to make sure your code button works in your ICU. So these vasodilators can either be venodilators or arterial dilators. And if they're venodilators, they're going to decrease your venous pressure and decrease your venous return. And if they're arterial dilators, they're going to directly decrease your SVR, your systemic vascular resistance. Starting us off, we have nitroglycerin. So we use this medication as a coronary artery dilator and a systemic venodilator. It's a direct vasodilator by means of nitric oxide induced vascular muscle relaxation. So what I'm saying here is it dilates the venous system and causes a pooling of venous blood and decreases cardiac preload. So at high doses, it can contribute to systemic arterial dilatation as well. As we know, the most common side effect is headache. With its strong venodilating properties, you really need to yield caution in the use of this in hypovolemic patients, those suffering an inferior MI, and a neurologically injured patient that's at risk for increased ICPs. We also should avoid this medication if the patient's on any sildenafil-like drugs, either for erectile dysfunction or pulmonary hypertension. Now, nitroglycerin can cause tachyphylaxis, and this is due to its predominant venodilatation. You also can see tolerance to this medication as well. So the dose range is anywhere between 10 to 200 mics per minute. So if we look at the pro-cons of this medication, the pros, this is a great medication to be used for decompensated, overloaded heart failure and cardiac ischemia. The cons of this medication is that higher doses are required to get additional direct afterload reduction. Next up is sodium nitroprusside. So this is a very potent vasodilator. This medication acts as a prodrug to nitric oxide, and it again leads to vasodilatation. So compared to nitroglycerin, it's a more balanced vasodilator, but there's still a predominance of venodilation. With that said, it reduces preload and afterload. It has a rapid onset and duration of action. The typical dose ranges between 0.1 to 4 mics per kilo per minute, which is a typical dosing that I saw historically, but apparently you can max out this medication to 10 mics per kilo per minute. However, that max shouldn't be sustained for greater than 10 minutes. But remember, in shock, we're using this for a SVR reducer and not so much as an antihypertensive, so these high doses won't be seen among our shock patients. And then lastly, it's worth noting that the drug needs to be protected from light with a foil or a tinted bag. So there's a handful of concerns when using nitroprusside. The drug can cause coronary steal syndrome. It can also increase ICP similar to nitroglycerin. It still has the issue with tachyphylaxis. And there's a potential for cyanide toxicity, thiocyanate toxicity, and methemoglobinemia. When we look at the sodium nitroprusside structure, it's a ferrous molecule with nitric oxide attached to it, surrounded by cyano. Yes, cyano, you guessed it right, cyanide molecules. The very brief explanation of mechanism of action is that sodium nitroprusside interacts with the red blood cells to produce nitric oxide. This leaves these 5 cyanide molecules. These are converted normally to thiocyanate and they're eliminated by the kidney. Now at high doses, the conversion of cyanide to thiocyanate can be overwhelmed and exhausted, causing actual cyanide toxicity. In addition, if the patient has severe renal dysfunction, the thiocyanate might not be eliminated sufficiently, and this might cause thiocyanate toxicity. Then lastly, at very high doses, sodium nitroprusside, hemoglobin is converted to methemoglobin, causing methemoglobinemia. Now these toxicities are rare, but we increase risk with high doses for prolonged periods of time. And in addition, patients with hepatic or renal dysfunction, malnourished patients, and patients with B12 deficiencies carry additional risk for these toxicities. So as you can imagine, newer medications have better safety profiles, they're easier to titrate, they're less workload for the nurse, and they don't need to be protected from light. So for these reasons, sodium nitroprusside use has significantly decreased. This brings us to our newer IV dilators, and this would be Nicardipine and Clevidipine. First, let's take a look at Nicardipine. So Nicardipine is a dihydropyridine calcium channel blocker. This causes predominant vasodilatory actions. There's no negative inotropic properties, no negative dromotropic properties. As far as chronotropic properties, it doesn't seem significant, but interestingly, this drug has no tachyphylaxis or reflex tachycardia side effects. This is a strong arterial dilator with little, if any, venodilator properties, so it reduces SVR, systemic vascular resistance. The dose ranges between 1 to 15 milligrams per hour, and some providers might go as high as 20 milligrams per hour in select patients. When we look at the pros and cons, as far as the pros, it has an excellent safety profile, it's easy to titrate, it takes less RN workload, and lastly, it's effective. Now the cons, the big con to me is the large fluid load. Now I notice that providers sometimes dismiss the significant fluid load, so let's do some quick math here. So the dose range is between 1 to 15 milligrams per hour. Let's be conservative and say that your patient needed 10 milligrams per hour. It comes in a concentration of 0.1 milligrams per mLs. So for 10 milligrams an hour, this would run at 100 mLs per hour. That would be 2.4 liters in 24 hours. So nearly 2.5 liters in a 24-hour period. Well, this is a fantastic example of hidden or obligatory fluid excess that we discussed in our volume part 1 lecture. This wasn't fluid you intended to administer to the patient. This is especially important if for treating a patient that has or is at risk for fluid overload. So if we have a central line, we can double concentrate the Nicardipine to 0.2 milligrams per mLs. This would run our 10 milligrams per hour at 50 mLs per hour, but still we would be in excess greater than a liter per 24 hours that we didn't account for. Now, this situation is probably more commonly seen when we're treating a hypertensive emergency. At least in my experience, we don't run that high of doses when we're treating a high SVR situation in cardiogenic shock. However, you do need to remain cognizant of this situation. This brings us to discuss Nicardipine's younger brother, Clevidipine. Now this medication too is a calcium channel blocker. It's a very potent, pure arterial dilator, so this reduces our SVR. Now through some chemical altered magic tricks, this is actually a racemic mixture medication here. With that, it's metabolized by the blood and tissue, and this renders the medication an extremely short-acting IV antihypertensive. Now because of this ultra-fancy chemistry needed to make this drug, it's barely soluble in an aqueous solution, so it's compounded and manufactured in a soybean lipid oil. It has a very rapid onset of 1 to 2 minutes and a duration action between 5 to 15 minutes. As far as half-life, it has a biphasic half-life of 1 minute and 15 minutes. So to summarize that, it has a quick onset and it's rapidly metabolized. The dosing is interesting. You start at 1 to 2 milligrams per hour, and then you can double that dose every 90 seconds to effect. Now, at least for hypertension, it looks like the average dose is between 4 to 6 milligrams per hour. But again, remember, we're using this for shock for SVR purposes, so it's going to be much lower. If we are using this for hypertension, the soft max is about 16 milligrams per hour, and the max dose isn't well established, but it's reported to be 32 milligrams per hour, but there's definitely limited experience with this dose. So the pros of this medication, it's low volume, it's rapid on and off, and there's no dose adjustments or concerns based on the kidneys or liver. The cons of this medication include its lipid base and its expense. Like other drugs like propofol that are lipid based, we need to remember the bottles are only good for 12 hours once we spike them. We have to be on the lookout for hypertriglyceridemia, pancreatitis, and rare lipid metabolism defects. We also need to remember that the drug provides 2 calories per ml of solution, so we need to take this into account when looking at our daily caloric intake. Then we get into the debate allergy on soy and egg products. Now these are purified soy and egg proteins, so it's unlikely these will affect your patients with allergies, but for matters of liability's sake, I'm going to tell you to stick with the package insert, and then you can research and form your own clinical perspective and opinion. In addition, its cost, at least in the land of vasodilators, is high. Running at conservative doses, we'll say 5 milligrams an hour, it's going to cost about $350 per day. While it might be initial sticker shock, I think we can make the argument, or at least the hypothesis, that this cost in select patient populations might be a wash when considering avoidance of fluid overload. So this concludes our short lesson on vasodilatory medications that we use for cardiogenic shock. Up next, inopressors.